Hello, welcome to the ACC meeting Ohio chapter. My name is Dr. Basharat Ahmad and I am one of the PGY-4 Fellows at Aultman Hospital, Canton, Ohio. These are the team members for my presentation, and I am presenting this interesting case of Takotsubo cardiomyopathy in elderly female with history of Crohn's disease. Introducing the case, as Takotsubo cardiomyopathy is a condition associated with transient left ventricular dysfunction that recovers following weeks to come. Most common known etiology is stress-related catecholamine release. On the other side, Crohn's disease is an autoimmune disease and cause of intestinal inflammation with extra-intestinal manifestations. We present a unique case of an elderly lady with presented both of these conditions. Main objective of this presentation is to focus on less possible causes of Takotsubo cardiomyopathy that have not well-established relationships. So coming to our case, 75-year-old lady presented with the history of Crohn's disease on mesalamine therapy. She had sudden chest pain that started for one day and she appeared to be fluid overloaded on presentation. She had history of complications from Crohn's disease, including intestinal strictures that required surgery. She is currently heavy smoker and smokes 1 pack of cigarettes every day. On assessing her Crohn's disease activity index, it showed mild to moderate disease activity. On arrival, she had EKG done and that showed a new onset left bundle branch block that was not present on the prior EKGs. She had elevated troponin as well. Echocardiogram revealed diffuse apical hypokinesis with reduced left ventricular function, and it was counted to be as 10 to 15%. For acute coronary syndrome, she was taken to the cath lab and it showed normal coronary arteries and reduced LV function. Here in the pictures you can see the images from the heart cath. It shows one single view but normal coronary arteries here. Here is the echocardiogram that was done. It shows apical hypokinesis, although it's not well without the motion of the pictures. Continuing the discussion for the case, Takotsubo cardiomyopathy predominantly affects the postmenopausal women, and Crohn's disease occurs due to mucosal damage by inflammation. Our patient also had MRI that further provided evidence of Takotsubo cardiomyopathy, reporting myocardial edema consistent with the wall motion abnormality. It was done 2 days after the presentation and it already showed improvement in the ejection fraction. Patient was managed for fluid overload due to clinical acute heart failure with goal-directed medical therapy, including beta blockers, ARBs, and diuretics. She had elevated inflammatory markers. Mesalamine was resumed and she was continued to be monitored for any flare-ups. You can also look at the lab work. She has elevated C-reactive protein as well as elevated ESR. Other more likely etiologies like substance abuse, tick screen, and emotional stress were not found in our patient. Patient achieved euvolemic status and she was discharged with recommended follow-up in 3 months to assess her LV function, as well as she was advised for the healthy lifestyle modifications including smoking cessation. Concluding my presentation, pathophysiological effects of Crohn's disease involve endothelial dysfunction leading to transmural inflammation, and elevated inflammatory markers show the disease activity. Takotsubo cardiomyopathy is a predominant in postmenopausal women and our patient had risk factors for that. However, there was no stress reported by our patient. Both Takotsubo cardiomyopathy and Crohn's disease are separately associated with the stress as risk factor, but direct correlation of these two is not well established. The only risk factor was smoking in the patient. So we should be vigilant in encountering such patients with wide possibilities of the disease cause. Hence, further studies are required to explore the correlation between the Crohn's disease and Takotsubo cardiomyopathy. Thank you so much for listening to my presentation.